Hello, everyone, and welcome to Hatching a Plan, episode 5. My name is Simon Tomes. I'm Emma the embryologist, aka Emma Whitney's husband, and we are here today to run an Ask Me Anything. All right?
Yeah.
Ready for this?
Yeah.
So we've had quite a lot of questions come in, haven't we? So
Yeah. You're going to keep me on my toes, that's for sure.
yeah, we're going to go rapid fire, aren't we? We think that's probably the best way to do it, just to jump straight in.
Let's go.
But first up, thank you for joining us. Wherever you may be, feel free to pop where you're visiting us from or tuning in from today on the chat. We can see on the chat. You can ask questions on the chat as well. I do have a massive list of questions for us to go through. So if we don't get to the questions in the chat, we'll do our very best to, I don't know, we'll work it out. We'll work it out.
It's fine. Yeah.
So for those unfamiliar, I guess we should dive in, just taking a step back. Why are we doing this podcast and these live webinars? What's the thinking behind it all?
So I think over the years of doing embryology, I've realised that a lot of people come to this journey, I hate that word, but it is what it is, with anxiety. And I think a lot of the anxiety is from unknowns and misinformation and everyone jumping on the fertility bandwagon, Dr. Google. And I figured that actually it shouldn't be that hard to get good information. And given that I have been in this job for 22 years, I've probably hold quite a lot of the answers to what I think is my day to day. It's actually massively overwhelming to many people. So
yeah, well, you've helped thousands of people, and we want to help a load of people today. So this is available as a podcast. You can go to emmatheembryologist.com. Look for the link to podcast. We've got 4 episodes out already. I'll give you some details about them a little bit later, so stick around for those. And also some information about some of the posts that Emma has been putting out on emmatheembryologist.com. Some good stuff, but we will come back to that at the very end. So some folks checking in. I'm just going to check on the chat. Here we go. Oh, wow, lovely. So Emma from Bristol, Haley from Southsea, Maria, hi from New York. Wonderful. Sarah from Manchester, Chloe from Reading, Catherine from Walton-on-Thames, Surrey. Oh, that's quite near us. Leon C, Lincoln. This is great. Thank you for tuning in, folks. We're very, very grateful. Jump straight in?
go.
Right, so bring up my questions. Go. Okay, so...
I feel like we're in that gladiator show. Gladiators, ready. Sorry.
Yeah, no, it is. It's fine. No, it's good. It's
Maybe
good.
I'm showing my age. Although that is now back on the TV, so it's fine.
It's fine. It's fine. I think, serious topics, but we've got to keep it light as well. But we're going to get serious when we need to get serious. So let's do that. So Amy asks, how long have we been implanting biopsied embryos?
I love that question. So, biopsying embryos has been around since the mid-90s. Alan Handyside, which is one of my I'm not worthy people, started biopsying embryos in about 95, I think the first paper came out. But you've got to remember that they were always biopsied on day 3 when we started doing it. So day 3 embryos are only 8 cells big.
So very quickly, question for you. What does biopsying mean?
Wow. See, this is why you're here.
This is why I'm here.
Because otherwise, I just start ranting on.
Yeah, you get all sciencey.
Get all into my zone.
What is a
La,
biopsy?
la, 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 la.
So
a biopsy is when we take a small sample of the embryo to try and understand its genetic health. So normally we're looking for chromosome copy number, which is the genetics being the compatibility with human life. Sometimes we're looking for genetic disease, such as cystic fibrosis. Sometimes we're looking for things called a translocation. Ultimately, we're taking a sample of the embryo, so a cell or cells from the embryo that will allow us to see into the embryo.
Brilliant.
Okay. So back until about 2010, we were biopsying or taking a single cell from day 3 embryos, which we now realise to be absolutely bonkers because it's only 8 cells, and by taking a cell, you're taking a whole 1/8 of it. So you could actually be damaging its road to going onwards. It did used to work, but not as well as it does now.
And throughout your whole career, how many of your patients have you had to biopsy? Is there a ratio of how typical it is to biopsy these days?
So now it's really, really common to do PGTA. I think 60% of my treatment cases are PGTA just because of the age of the patient that comes to it. But we used to biopsy on day 3. So in answer to Amy's question, how long have we been implanting biopsied embryos? Since 1995, but they used to be day 3. And then in 2010, we all switched pretty much to biopsying day 5 embryos, where
right.
you could take more than one cell. You can take 5, 6, 7 cells, because the embryo at the stage day 5 or day 6 is a blastocyst. It has 150 to 200 cells.
And if you want to learn more about PGT, we've got a great podcast episode on that, a whole dedicated episode where we went deep into that world.
So we did, and I've got I think there's an article as well, isn't there?
There is.
Somewhere.
Yep.
Yeah,
We got that.
I've written that, haven't I?
You have written that. We can come on to that. I'll give you a list of some of the good stuff that Emma's been writing about, as well as the stuff that we've been talking about on the podcast. So great question, Amy. Thank you for that. Okay, Holly Louise asks, first 4AA FET from batch, 12 frozen embryos ended in TFMR for a trisomy, no translocation. We're sorry to hear that, Holly Louise. Would you recommend PGTA for the remaining 11? Is there an increased likelihood now one was aneuploidy?
Really sorry about the TFMR. I think anyone that knows us knows that we also have been in that awful position. So a trisomy, for anyone listening, is when there's 3 copies of a certain chromosome. So actually Down syndrome is considered a trisomy because it's 3 copies of chromosome 21. It depends how old you are. So if you are dealing with a batch of 12 embryos and you are under 35, the chances are you were just really, really unlucky. If you are older than that, then the percentage chance of the remaining embryos being abnormal is in keeping with your age. I've got a really nice post on my Instagram about percentages of aneuploidy in age groups versus the day of the embryo being frozen. So it really depends. It doesn't mean that the others will be more likely to be aneuploid just because you've had one that was aneuploid, but the others will be in keeping with age and day of freeze.
Got it. Thank you for your question, Holly Louise. Let's jump to Maria. Maria asks, what are the chances of an aneuploid being retested and then being a euploid? So before we jump into that, can you very briefly say what an aneuploid means and what a euploid means?
So aneuploid is when the embryo is abnormal, which means it's got an incorrect copy number of chromosomes. So for example, a trisomy, like Holly's just talked about, is 3 copies of a chromosome. So it's, instead of having 46 chromosomes, it's now got 47 or 48, depending on what there is. And a euploid embryo is what we consider to be normal. So 46 chromosomes with no losses or gains. What is the chance of an aneuploid embryo being retested? So this is a really good question, and it actually depends on who the genetics testing laboratory is a little bit.
Okay.
And also the technology being used. So over the years, as you can imagine, the technology's changed quite a lot. So we used to use... so if you were talking about an embryo that was 10 years old and we used the technology we used 10 years ago, then there would definitely be a probability that a certain number of those would probably come back different to what they did, but we were using the technology that we had at the time that was the best we had at the time.
Yeah.
So the technology we have now is far more robust. So I think if you had anything tested in the last sort of 3 or 4 years, then you will know there's no evidence that an aneuploid embryo will come back any differently if you retest it. That it's pretty robust now. But if you're dealing with an old embryo, then it's different testing now, right? So you move with the technology with your time. So at the moment, no, there is no evidence for what I'm testing now is coming back any differently. They've actually done quite a lot of studies on this where they retest embryos that are donated to science to see if the technology is working. So if that makes sense.
Yeah, absolutely. Very interesting. Okay. Let's jump into... Did you want to take one from
I was
chat?
just seeing how many we had on here.
Oh, yeah, there's lots coming in. So if we want to whiz back to the top perhaps and take one of the earlier ones,
I
can do that for you. Okay, so...
I think that's in there as well, so that's probably quite a good one to cover.
So the one from Emma.
Yeah.
Yep, so question from Emma. Emma asks, question about embryo glue. Is it worth trying it for my 3rd euploid FET next week? I'm 33 and so far unsuccessful with medicated FETs, but this will be my first time trying a natural FET. I read up a bit on embryo glue. There is a link study on the HFEO website. So FET is an acronym for those who are unfamiliar.
Frozen embryo transfer.
Frozen embryo transfer. Okay, for those unfamiliar.
So firstly, I think one of the questions we had actually came in earlier is, what is embryo glue? So embryo glue, firstly, I mean, let's give the round of applause to the people who called that name up. I mean, it's clever, right? It
Yeah.
makes you sound like it's like some sort of amazing sticking power.
It really does.
I have actually met the person that came up with that that name, and
And
I
is
did
that-
actually say to them, "Well done."
They've actually got the name represents exactly what it's doing.
Well, no, not really, because I
Ah.
think people think that embryos have got to stick to the lining. They don't actually. They don't stick. Nothing sticks. It's like, if you can imagine an embryo. In fact, let's cover all these questions off, because there's a question that came in earlier about what happens when an embryo goes back after you put an embryo back, right? So let's talk about implantation. So what actually happens is an embryo will go back. If it's not already left its shell, it will leave its shell. Then there has to be a communication. There's lots of signals between the lining and the embryo. And actually the embryo doesn't, although the embryo sort of invades the lining, it doesn't stick as such. And the lining actually has to engulf the embryo. So it almost like it gobbles it up, really.
Yeah.
It's quite,
Yeah.
if you watch it, it's fascinating. So there's lots of signaling and lots of communication between the lining and the embryo, and then it all goes like invades into the lining, and then it burrows in and it starts filtering into its own blood supply. Hence, then you get a pregnancy. But embryo glue is a hyaluronic acid rich medium, and the reason it's meant to work is it's meant to help that conversation between the two. I will hands up say we're in an embryo glue trial at the moment, actually. It is not detrimental whatsoever. I 100% hand on heart does not think that it's a bad product. Whether or not it increases pregnancy rates, I'm not sure yet. We've got a bit more data to do. It's definitely working very well. But I think, I always say this over and over again, it's about the context of the patient. Emma, you've had failed transfers. So then the question would be, if you don't use this product and you get another negative test, I think the point of regret will be quite high. It will be, what would have happened if I'd done this? And
Yeah,
I can hand on heart tell you, it's not detrimental. It's actually a really nice media to work with as an embryologist. It's a bit thicker. It gives you a bit more control. Whether or not it's worth the price tag and whether or not it will give you your positive pregnancy test, I'm not 100% sure about yet. I don't think it's a magic wand, but I know it's not harmful.
Yeah.
So I think it's worth a go.
Great advice. I hope that helps answer your question, Emma. Thank you for asking. Okay, let's jump on in. Let's have a look. Let's take this one from Chloe. So here we go from Chloe. Thank you for your question, Chloe. Does the AMH level impact the embryo quality? I have lower AMH than the average from my age, and I'm about to start my first cycle, and I'm quite anxious due to my low AMH. Well, sorry to hear you're feeling anxious, Chloe, but let's hear from Emma
So
on this one.
AMH, anti-Müllerian hormone, is all that tells me about is how many eggs I'm likely to get from your ovaries when we give you stimulation. Your AMH doesn't tell me anything about the quality of your eggs. The only thing that tells me about the quality of your eggs is your age. So you can actually have people that are in their 30s, like early 30s, with a really low AMH. Their chance of getting pregnant, you've got to remember that we're not testing Joe Bloggs on the streets AMH. We're not looking at everyone who's getting pregnant. So all it tells us is potentially that you're in an ovarian decline earlier. Equally, that might not be the case. You may actually have the same AMH for the whole of your life. Like some people have just naturally got a low AMH. It does, if you're ovulating and you're cycling properly, AMH shouldn't be the reason that you're not getting pregnant, because it's to do with the age of the egg. What it does mean is if you do end up coming to IVF, it's a bit more challenging because you don't get 20, 30 eggs. You get a smaller number of eggs because that's all that we can get from you with what your ovaries will give us during stimulation. So no, AMH tells me nothing about the quality of your eggs. It tells me how many I'm likely to get and what I've got to work with. And when I talk about the funnel, what my top of my funnel looks like. And then you advise patients based on that and how long that, how many cycles are we going to need, how much journey this is going to look like. But no, it's not to do, your age is still the sole defining factor of quality.
Yeah.
And chance of implantation and working.
Do we want to talk more about age, or should we jump into questions?
Go for questions.
Go
I think
for
it's going to come up.
questions. Yeah, of course. Thank you for asking that, Chloe. All right, let's take. Did you want to point at one that you want to take? This one here.
Yeah,
Brilliant.
It's a great question.
Great question from Kate. Hi, Emma and Simon. From a theoretical, scientific point of view, how many days could you keep growing an embryo in culture for? Whoa, great question.
I love this. So you are legally allowed to keep an embryo in culture under research purposes for 14 days.
14 days. Okay.
There is a reason for that.
What's the reason?
So at 14 days, they think that the neural tube starts to form, which is your nerve endings.
Oh, I see. Right.
So they think there is a
Yeah.
potential for something to be able to have feelings.
I get it.
I'm completely do not agree with that, by the way.
Yeah,
because
of course. Yeah.
So actually, yes. So physically, in a laboratory like I've got, I don't think I could sustain an embryo much longer after it has left its shell than about 24, 36 hours, because it is looking for a blood supply. It needs more than the culture media surrounding it.
Yeah,
But in
fascinating.
certain research labs, they can add probably things that we can't add to the media to help the embryo survive.
Yeah.
And actually, in certain research labs, they have kept the embryos till, like I said, legally in this country, it's 14 days. In other countries, they don't have many laws. So it all gets a little bit wayward. But yeah, you can definitely get what we call differentiation of embryos in the laboratory, and you can
Right.
start to see it forming into certain aspects of things. But you probably, I mean, I don't know of all the data, but I know that, you can keep them alive. But not beyond probably 20 days, 25 days, I wouldn't have thought. You can't sustain life without a uterus and a womb and all of that. I don't think we're quite into Brave New World just yet. Maybe not far off, but
Not quite.
but yeah. So the legal requirement in this country is 14 days.
Fascinating. That is a great question, Kate. Thank you for that. Could see Emma's geeky science brain
Love
light
it.
up at that
Love it.
question. So
Blows my mind that you can do that.
yeah, it really is fascinating. Should we jump on to some of the questions we
Yeah,
had
sure.
from Instagram? Okay, so let's take this one from Stydale, their username. They asked the question, what's the most important thing to consider when choosing a clinic? Big question. Now, just before we dive in, we do have
This is my favourite topic.
we have
We've
an
got
episode
a
on this.
whole episode on this,
Whole
and it's
episode on
called,
this.
because I actually think the most important thing when choosing a clinic is you understanding what's called the Vienna Consensus.
So check out a previous episode, Vienna Consensus. You can get that on emilyembryologist.com, select podcast, and you'll find it there. We also have a post called 10 questions to ask your IVF clinic to help you decide which one to go with. That is a very good post. Emma shared lots of good info. So yeah, go for it.
So I think, so for me, where you have your treatment and where you choose your clinic has to be led by your context. So what is your context? Why are you coming to this clinic? Why are you needing treatment per se? So for example, if it's for genetics, I think you need to be making sure that there's someone in the building that understands genetics. So I'm a genetic expert in embryology. I'm quite a rare breed because I came to this quite in a different way. But I also think that you need to make sure that you understand what's important to you. So does the clinic grow embryos to day 7, for example? Are they going to keep them growing?
Yeah.
Will clinics allow you to use time lapse? Because I still think that is one of the most biggest advancements we've ever had. Is the clinic going to monitor you properly? So I think anyone that's having treatment should have at least 4 scans during their stimulation journey. Are you going to have, a consultation? Is it going to be bespoke care? Are you going to be, all of these things that are really important to you in that list of questions that I put together? For me, those are the things that you need to consider when choosing a clinic. Do they freeze average quality embryos? Are you going to be involved in that discussion? Can they do genetic testing if you need it? There's so much more to this than just different clinics offer different things, and it really depends on what your needs and your context is. So some people need really, really high level of care. Other people don't. I mean, some people don't need it. It's really, really dependent. So the first thing I would say is what is important to you.
Yeah. And I guess some people might they might not know what is important to them. So they need to have conversations with lots of clinics to get a sense of what
lots
that
of clinics
is.
actually do open evenings as well. If you can tap them up, lots of them do 15 free, like we do a free open evening or a free 15
Where's
minute
for people that don't know
Sorry,
where
the
you work?
Evewell. I work at the Evewell Harley Street or the Evewell Hammersmith. They offer 15-minute free consultations or like an open evening thing, so you can get a feel for the doctors and stuff. So that happens in quite a lot of clinics.
So the questions, and please do come to this post after this session. Emma goes into detail as to why you want to ask these questions as well. So the top 10 questions that we came up with was, how will you treat me? Oh,
No,
sorry,
will you
not
treat
how
me?
you
Because
treat me.
actually, there's
Yeah.
a lot of cherry picking that goes on.
Exactly. Yes.
And actually,
Yeah.
some clinics won't treat certain, like going back to Our Lady earlier with the low AMH, there are some clinics that won't touch you with a low AMH because it affects their success rates. So you are
Yes.
more difficult to treat.
Yeah.
So the first question you've got to ask is, will you treat me?
Yeah. And then we have, what are your success rates? What is your multiple birth rate?
But I'm going to talk about that. Why do I ask what is your multiple birth
Well,
rate?
you tell me. Why do you ask?
Because if it is really high, someone is relying on unethical practice. Your multiple birth
yes.
rate should be less than 5% in this country. Our multiple birth rate is 1.6. And that's because embryos sometimes are little monkeys and split and you end up with identical twins.
Yes.
So a multiple birth rate of clinic can tell you a lot about their practices. It should not be, the HFEA have put a rule on it that it should be under 10%. The HFEA is the Human Fertilisation and Embryology Act, because I know you're looking at me because I'm not explaining it.
That's my acronym face. So when I look at Emma to say, you just said an acronym and you need to say what that means.
So it should be under 10%. If it's over that, then someone isn't practicing ethically. It's not good. You know, twins sound like a great idea. That it's a very complicated pregnancy. So I just want to get that in there.
Absolutely. Do you run a 7-day service?
And that isn't because about culturing embryos. Sorry, you got
No,
me on a
all
roll.
right. This is it. These are good points.
And that's not because of the whole 7-day culture of blastocysts, but you should, if you are running a 7-day service, it means that it doesn't matter what day your egg collection is to what treatment you receive.
Yes. Yeah.
So just because you have an egg collection on Tuesday doesn't mean you shouldn't be able to have a blastocyst put back on a Sunday. That's really important.
Yeah. How is the embryology team set up? How much will it cost? How long will it take? What do we need to do before we start? That's a great question. What support do you offer? And what can I do to increase our chances?
Yeah.
Check out that post.
It's really good. Took me ages.
Yeah, we worked on that one for a while, but those are essential questions to help people get started. So do you want to take one?
Yeah, there
from
was, because
here?
actually, Archner's, where was it? It was here, this one.
Oh yeah, from
Archner.
Archner. Brilliant, who I believe has joined us on a number of our webinars. So thank you, Archner, for joining us again. Appreciate that. Hello, where do you think the science of embryology is going? What has the potential? It is on the verge of moving things on, or what's exciting for you? Great question.
So there's quite a lot of exciting things going on at the moment. So I think the way we're all going now is we're starting to understand, like I think I've done a couple of posts on this as well, we're starting to understand that embryos haven't read the textbook. And just because they don't behave a certain way doesn't mean they're not viable. So actually a lot of my work at the moment is trying to go into understanding embryos that maybe before hadn't been utilised because we couldn't safely do it, to how we then turn it around so that we can safely use embryos. So what I mean by that is things like when they don't look like they fertilise normally, how can we then test against them to make sure that patients can actually utilise them? There's a lot of stuff going on with AI, but not so much AI in regards to, I don't think AI will be as brilliant as everyone thinks it is, but it will help us as a team start to have a better work-life balance. Have no mistakes about this, guys. Embryology is one of the most stressful jobs you can do. You're in a lab for 8 hours a day, handling people's dreams in your hands. It's brutal, but it's wonderful, but it's hard. So AI is definitely going to be what helps take the edge off the repetitiveness of it, I think, and everything like that. It's quite exciting.
Yeah.
And what excites me is a couple of the genetics papers coming out of the US that I think will help us again understand genetic science a bit more and utilise embryos more. So
Fascinating.
watch this space, because I'm at the front of this, so I'm trying to get
there's
massively involved.
Thing you probably can't talk about.
Probably can't talk about.
Okay,
it's definitely very exciting.
Let's move on from that. That is a good one. Thank you for your question, Archner. Really appreciate that. Okay, should we take this one here?
No, I don't. Hold on. Here.
This one?
Yeah.
Okay, question from Susie. Thank you, Susie. Can you disturb embryos too much? We've just thawed and biopsied our remaining 3 embryos, then refreezed, but now debating moving clinics, therefore disturbing the embryos again.
That is a great question. So yeah. I love the term disturbing embryos. So we talk about non-disturbing embryos, especially when we're culturing them, because we like to keep them in an incubator where they should be. So that's why time lapse again is so brilliant, because you don't have to touch them for 5 or 6 days. Yeah. In regards to disturbing them when you're moving clinics, they don't actually get disturbed, because if you can imagine, they are in, I can't explain it, but it's like a tube and it's full of liquid nitrogen. Yeah. So they're immersed in liquid nitrogen.
So essentially they have no sense of being moved.
No, so they won't. Yeah. So I suppose you have to accept that the more we do with embryos, the more risk there is. If you're
Just
doing a
'cause
risk assessment, just because you're doing stuff
yeah,
with them, we're
yeah.
humans, and there's definitely that.
Yeah.
But I would say that they are non-disturbed when you move them between clinics. They are kept under liquid nitrogen the whole time. We're also really used to doing it, so it's something that's incredibly safe. So that wouldn't concern me. What would concern me is you're in a clinic, you feel comfortable to have them transferred back into you.
I see. Yeah, great question, Susie. Hopefully that answers your question there. I think that was a follow-up from an earlier question. Let's see if we can find that. Oh, I might have missed that one. Let me see. Oh, there's so many questions coming in. Thank you very much. I might have missed that one, but right, let's jump to some of the questions we had coming in from Instagram. So this question from Natalie: if egg fertilized in ICSI and defrost successfully, does that mean implantation failure is the female issue?
Yeah, that's an impossible one because I don't know the age of the embryo, the age of the egg that created the embryo. So an egg can fertilize normally, it can create a blastocyst, it can be frozen, it can then be thawed out, it can then be put back. But if the genetics of that embryo are incorrect, then it won't implant. So that's not your implantation issue, that's the embryo's quality control. So what I would need to know about that embryo is, was it tested? There's so many variables around that embryo. Yeah. So no, not necessarily. So you've got two elements when an embryo goes back. You've got the embryonic control and then you've got the female implantation control. And ultimately, if the embryo's quality or genetics blueprint isn't correct, the quality control mechanism kicks in, and actually a lot of these embryos just don't make you pregnant. It's nature's way. It's bloody unkind, but it's nature's way.
But it's nature's way. It makes me think, like, variables often come up and you often use the word variable. Has any embryologist ever tried to map out all the variables and say, this type of variable has more impact than this other variable?
Yeah, we absolutely do.
And you literally map it out. Could we write that and post about it? So the variable, or is it just too sciencey? Is it too...
some of it's too sciencey, some of it is, and some of it's a bit... It's not noughts and ones, right? Just because it doesn't work for someone doesn't mean it won't work for someone else. Yeah. I think one of the variables that I talk about quite a lot is it day 5, is it day 6, is it day 7? That really correlates to implantation rate. And I think we've got a question somewhere about that.
Okay, let me try and find that.
But yeah, so the variables are very much like, that is a really big variable in embryo development and means a lot to me. So when people talk about grade of embryos, I always say it's what day was it? Because actually a day, and I'll say this probably time and time again, a day 5 4 BC will still make you pregnant, far higher rates than a day 7 5 AA. So it may look better on paper, but it took longer to get there. So its chance of actually being able to be implant and be a viable pregnancy is much lower regardless of how it looks.
And often I think I can gather that folks get a bit caught up on the scoring and what scores mean. What's your caveat to the audience today around scoring?
Grading.
Grading.
We're humans. We pick an embryo out of an incubator, we look at it and we give it a grade. And it's something that's dynamically changing. So the journey an embryo goes on is, in my mind, more important than the number and 2 letters we give it at the end, because actually how it divides, how it grows, when it makes certain milestones, all of that really correlates really highly to implantation. How it looks when an embryologist looked at it at 9 o'clock in the morning before it put it in the freezer is not really ultimately very scientific. I can call an embryo a 3 BC in the morning and my colleague might call it a 5 AB in the afternoon. It's a changing entity.
I see.
I think when embryologists try and speak to patients about quality and grade and all of that, what they actually need is the full picture of the context of that embryo. What did it look like on day 1? How did it get there? When did it get there? What movements did it make? All of these things are really, really important. So I always say to patients, don't fixate on the number and 2 letters. Because it's only part of the information, and actually for me it's one of the smallest parts of the information. Because also, I'll be completely honest, I am such a harsh grader. And probably because I've been doing it so long. So I have seen thousands, tens of hundreds of thousands of embryos. So my relationship with embryos, from experienced eyes, you could argue that maybe I grade too harshly. But then a junior who is got rose tints on or something. Do you know what I mean? So it's also, I think we would all agree that certain embryos are good, average, and poor. I think we would all put them in the right buckets, if that makes sense.
Because you're trained to do that.
Because we're trained to do that, but we're not all going to grade the same way. And I disagree so many times on embryos that come in from other clinics, and I thaw them out or I look at them and I just, for whatever reason, I just disagree.
Yeah. And I guess, I think of it like, because grading feels like it's quantitative, like that there is direct correlation, but you're kind of saying that it isn't. It's just
there is a little bit of correlation.
Indicator. It helps you make choices in a lab.
Yeah, actually, it's more of a language that we speak to each other. Yeah. So it's like if I say something to one of my colleagues and I give it a grade, then my colleagues know exactly what I mean by that. It's an indicator. It definitely correlates to something, but it becomes a fixation, and there's so much more to it. Yeah,
and you wonder, because we've seen quite a lot of misinformation about grading and that.
That chart.
The chart. Oh. Don't get Emma on a start on the chart.
Bloody chart.
I mentioned the chart.
It's awful.
Oh boy, you've
so angers me, that chart.
Yeah.
If no one's seen it, it's on my Instagram. I've pinned it. It's got a great big red cross on it.
Yeah.
Please go and look. It's awful.
We have contacted the place where it exists, and they're like, if you can show evidence that it's wrong, we'll take it down. And we're like, we have plenty of evidence that this is wrong, and they haven't taken it down. But
they get too much traction.
Again, that's the case of Dr. Google, that misinformation outlets. This is why we're doing what we're doing, to try and help clear up some of that misinformation that's going around. Just going to do a quick time check. We've got just under 30 minutes. Thank you for sticking with us, folks. Take a little breath. We've got a few more questions to go. Thank you so much. There's so much stuff coming in. What we are going to do, do you want one of these two?
That one on the left is good.
One on the left. So, Georgie on Instagram asks, can you tell egg quality just by looking at the egg?
No. No, you really can't. So it's okay, that's a lie. So if an egg is really dark and poor and granular and abnormal looking, then yes, I can tell you that. But actually, I would say 90 to 95% of the eggs all look the same. Wow. Everyone's eggs look the same, and you don't really get any determination of quality until you start turning them into embryos and growing them, which is why, light bulb moment, I find it absolutely fascinating that people think that you can give people egg freezing ultimate results on the other side.
Oh, I see.
Because how can you do that? But no, you don't know what sperm you're going to put in.
Yeah.
So when people come to egg freezing and they say, right, those eggs are really good and you've got about a 50% chance of any of them making a blastocyst, they don't know who you're going to meet, and they don't know what sperm's going in it. So how on earth can you tell someone that? I find that bonkers.
So who's giving that misinformation then?
There's lots of places now that will give you a report with your egg freezing saying that these eggs look a certain way and therefore they are going to be suitable for use in the future, and 50% of them are going to make blastocysts. But if you meet someone in the future from an egg freezing cycle who doesn't have any sperm or is a really poor male factor, that is going to impact ultimately on the embryos that you can create with those eggs.
Of course.
Madness. So so no, you can't tell egg quality, not from visually. Sometimes you can see certain things that might make us make comments about them. Equally, on the flip side, I've seen what visually looked really poor quality embryos that went on to make a twin pregnancy. So I've just stopped trying to guess, to be honest.
Yeah.
Eggs haven't read the textbook either.
They haven't read the textbook.
They don't know what they're meant to look like. They don't know,
I like that line.
There's no skincare routine. I don't know. It's
fascinating, absolutely fascinating. But I'm kind of unfortunate as well that there's companies out there that can kind of give you a bit of false sense of hope or
scaremongering and false reassurance. Yeah, you can't do that with eggs. You just can't. You cannot know. You just can't. It is what it is. And actually, certain stimulation protocols can make eggs look a bit funny, but it doesn't mean they're not genetically perfect. So it's a lot to do with that as well.
Yeah, I get it. Okay, so another few questions coming in. Here we go. And you can point at one, Emma. We're just having a read through. If there's a bit of silence on the audio, this one here from Todd. Thank you, Todd. I had embryos retested from 2018, defunct lab, that were abnormal, but retested by another lab in 2024, and 3 were euploid. Can I accept this, or do I consider them mosaic now? Newer tech? Question mark.
So that's really interesting. So it depends what the tech was. So I think this is what I was saying earlier about older style technology
Yeah.
now being reverted into the newer style technology and then being regraded. So when you say they were abnormal, I wonder what the abnormality was and whether it was partial abnormality rather than. So I haven't got time to get into this. I wish I did because it's really complicated. But the newer tech that we've been using sort of in the last 3-4 years adds an extra layer of certainty to the test results. So I think you need to probably consider the fact that they could be mosaic, but most likely no, the older tech just was incorrect.
For those unfamiliar with the term mosaic, what does that mean?
Mosaic means that the embryo has good and bad cells, and we now know that mosaic embryos are actually really quite viable at making pregnancies without too much affect. I've always used mosaic embryos. I find it hideously barbaric that people don't, but they are, again, their success rates is lower. So it's about making sure that the patient has genetic counselling to make sure they understand the theoretical risks around using embryos with an unknown, completely unknown entity of genetics in them.
And most labs will offer genetic counselling.
Yeah, most labs will. Oh, we've got our own genetic counsellors
So
that we use.
NHS as well?
Yeah, the genetic.
Yeah.
Well, no, because the NHS don't offer
They
PGTA
don't
testing.
offer, I get it.
So the NHS offer genetic counselling when you've got a genetic condition.
Yeah.
But not for PGTA. They won't offer it because
they don't offer that
don't offer
service. They're not able to offer it.
But genetic counsellors aren't too bad. They're about £200 for a consultation, and they're incredible. Like the people I work with are brilliant humans.
Yeah.
So.
Got it. Good question there, Todd. Thank you for sharing. Okay. Right. Let's take this one from
That's come up a few times today. That's why.
Rosie. Okay. So Rosie, you've asked a great question that's on everyone's mind. So the difference between day 5 and day 6, is D6 much worse or a bit worse?
A bit worse. So this is really interesting, and I think that this is something that I would love to highlight a bit more, because when I say what day was your embryo on, and there is a reason I asked that, because the pregnancy rates between day 5 and day 6 with euploid embryos, even with normal embryos, is reduced. So you get about a 6% loss between embryos that were euploid and biopsied on day 5. So they reached the blastocyst stage at the textbook time.
Yeah.
All those that took till day 6 to get there, there's about a 6% pregnancy change between them. Now, if that's in euploid embryos, when you're talking about unscreened embryos, so embryos that haven't been PGTA tested, the difference is actually a bit bigger, and that's because actually the longer an embryo takes to grow, the more likely it is to be genetically non-viable. So of my embryos, so for example, if in a woman that was 38, for example, embryos that I test on day 5, the blastocysts that I test on day 5, about 45% of those will come back normal. Okay, but of the blastocysts I test on day 6, only 35% will come back as normal, because they've just taken that much longer to get there. So that correlates into pregnancy rates. But equally, and this fascinates me, is that even embryos that take longer to grow, even when they're genetically normal, do not give the same pregnancy rates. So it is a bit worse. It's not huge, but it needs to be discussed, because you should go into every embryo transfer knowing what your chances of success are, and knowing your realistic outcome with the embryos you have in the freezer, so that you can make informed decisions about whether you do another collection or whether you've got enough in the freezer to create your family, for example. So that's what we talk about quite a lot, and that's why I try and highlight the difference between day 5, day 6. Now, day 7 is, when you said, is it a bit worse or much worse? Between day 6 and day 7, it's much worse.
Right.
Because anything that's taken, genetically normal or not, it's not functioning properly. So its implantation potential is actually quite small.
Yeah. And you said about having discussions about family. What do you mean when you say that?
So patients that come to you in a clinic, having been trying to conceive for a really long time, I think we need to accept the fact that actually by the time you get there, and I'm sure anyone on this podcast will not mind me saying how desperate you feel once you walk into a fertility clinic, because you probably either been through something really awful that's left you there, or you've been trying for ages and actually you're just beside yourself. So all you want to do is get pregnant. But if you're stood in front of me at 38, the most kindest thing I can do for you is say, right, fine, we can get you pregnant, hopefully get you pregnant now, but if you only create a couple of embryos and I put one embryo back and I get you pregnant, that's brilliant. But by the time you've had that baby, you've looked after that baby and you're ready to have a sibling, you're going to be nearly 40.
Yeah.
And it's going to be that much harder to create more embryos. So sometimes the difficult conversation is we might just need to pause for a couple of months whilst we make sure you've got enough embryos to potentially have the family you dreamed of before this all got so crap.
Yeah.
So we talk about family building more so than sometimes most places, I would say. And no, some people don't want to hear it, and that's fine. But I've been there. We've been there. It's, you do just get this desperation over you, and you just need, sometimes it takes someone like me to say, whoa, what did it all look like before it all got so awful?
Yeah.
Let's have that chat and let's see if we can make that happen. Yeah. So.
That's good. It's important, and you can totally understand why people just can get fixated. I just want
you're desperate, and
this. I'm not
all
thinking
so
about
hard.
Not thinking about a second, third, or fourth sibling like that.
But you will be. You will be in 18 months'
be,
time.
yeah.
You absolutely will be, and that's okay, and that's the conversations we need to have.
Yeah.
You're never going to be as young as you are today.
Yeah, it's good to emphasise that point. Absolutely. Thank you, Rosie, for asking that question. We're going to jump back to some questions that have been coming in on Instagram.
Done that.
This one. We've
done
that one.
Yeah, see, I'm cracking. Those are quite good because that's PGTSR. So
one?
yeah.
Yeah. Okay. So Alicia asks, for anything in particular when creating embryos, obviously PGTSR, but curious if anything else.
Oh no, she's talking about translocation. So a translocation is
okay.
something that some people have where they have all the chromosomes. There are 46 chromosomes, but they're in the wrong order. Okay, so it's called a translocation. So you actually end up making eggs and sperm, what I call as gametes.
Yeah.
With more abnormalities than normal because everything gets shifted around the wrong way. So that's called PGTSR. There's nothing in particular. We do always do ICSI with PGTSR. There's another question there about PGTM and how long it takes. So PGTM, for anyone who is listening to this, is when we're looking for an inherited genetic disease, like things like cystic fibrosis. And someone asked us, how long does it all take in regards to how long does it take from doing the cycle of treatment to getting to the embryos being put back? And what I think is really interesting is it doesn't actually matter for me what genetic testing you're doing. The process is the same. I would create embryos, biopsy them, and then send them to the lab. It's the testing that's done in the lab that differs. But ultimately, the turnaround time for the results is always 2 weeks.
Oh, wow.
Regardless of what test
Always
you're
2
doing.
weeks.
Yeah.
Wow. There you go.
The only thing to say is with PGTM, you do have to do like a 6-week workup though. You have to give them like lots of information about the patient so they can make the test quite bespoke.
It's a good reminder, all these acronyms coming in and all this terminology. If it's unfamiliar and it's like, flipping heck, this is overwhelming, which it can be, right? Absolutely. Emma has created a very good glossary of terms that you can find out. So if you head over to emmatheembryologist.com, I think there's a link at the top or in the footer called glossary of terms. It's a post called Things You Might Hear in an IVF Clinic. It's a huge list, quite an overwhelming list. It's in alphabetical order. You can do a keyword search and just get a bit of clarity on some of the terminology. But if there's something on there or something you've heard that's missing, then get in touch with Emma and say, look, I've heard this thing, whatever it is, and I don't know what it means. Send Emma an email.
I might not know.
Yeah, well, we'll find out.
But if
right?
I don't know, then it's probably not in much
it
use.
It should be on Emma's
If
radar.
it's not on my glossary and I
Yeah.
don't know what it is, then I will either add it or I'll tell you it's nonsense.
But you can contact Emma via the website. So just head over to emmatheembryologist.com. Go from there. We're going to take this one from Emma. Okay. Oh, no, we're not. We want to share.
Oh, yeah, no, that one. Yeah,
Yep,
that's
that one. Okay. So in one of my egg collections, my eggs were described as oval shaped.
Yeah.
That egg collection was my worst yielding round I ever had. Could it be linked? And why would my egg be oval?
It's probably not linked. They do just sometimes come out a funny shape.
Yeah.
I had one embryo once that developed and made a baby actually. And on day 3, it looked like a Christmas tree.
Wow.
It was like a really funny shape and they lined up so it looked like a Christmas tree.
Yeah.
I've got a picture of that on my phone somewhere. No, shape shouldn't really be a problem. Why are they oval shape? I have no idea, my love.
Just happens.
They sometimes do.
Just happens.
Most, it's really interesting actually because most embryos are just beautifully spherical.
Yeah.
But sometimes you get them and they are just an unusual shape. It doesn't normally correlate to anything. It's just probably a bit like people.
Yeah.
Funny shapes.
Still funny shapes and sizes. 100%.
And I was
Great
going to do
question.
this one actually
Great
as
question,
well
Emma.
because this one's really good.
Okay, this is coming in from Sophie. Thank you, Sophie, for asking this question. We've just done our first round of IVF. 10 mature eggs collected, 8 fertilized, 7 made it to day 5
Which
and were
is
frozen.
brilliant.
Amazing. I was day 6.
One was a day.
Oh, sorry,
one
misread
was
that. One was
day
day 6
6
CC, not frozen. Grading was 2 plus 5 AA, 3 plus 4 AA, 1 times 5 BB, 3 BB. The lettering part of it I kind of understand, but what gets me is the number. All of them were day 5 embryos, so I don't get the number difference. Any guidance here?
So the number doesn't correlate to the day. The number, I think that's a real misconception that people think
Yeah.
A5 is a 5. So the
Yeah.
number correlates to how big the balloon of the embryo is. So imagine when an embryo is forming, it's filling up with fluid. And the reason it's filling up with fluid is as it's filling up with fluid, the cells are dividing. So the embryo is forcing itself out of its own shell. So
Yeah.
it gets bigger and bigger and bigger and bigger until it makes cracks in the shell and then it leaves the shell.
Yeah.
So when we talk about embryos and being blastocysts, we start with the number 1, which is a very, very early blastocyst. It then goes to a 2, 3 is full but not expanded, 4 is expanded, 5 is hatching, 6 is hatched.
Yeah.
So we use the number to talk about how advanced the embryo is in its journey through its blastocyst phase.
But nothing to do with
It's nothing to do with the day.
day.
No.
Yeah, I can understand that misconception,
Really, yeah, it's
misunderstanding.
really interesting.
Yeah. I wonder if it's worth updating the terminology to avoid that confusion of, I don't know what else you would choose, but
No, because everyone tries, like, that's been around for so long. David Gardner did. It's the Gardner grading system. Most of
Right.
us use it. And when people don't use it, it really annoys me because again, it's the language we speak to each other. So
Yeah.
it's like someone not speaking that language, but trying to describe the same thing.
I think it sounds like you need to create the Whitney grading system.
I haven't got time.
Establish that.
Can you
Yeah, we
imagine?
should.
Yeah,
We should.
Yeah.
Don't worry, folks.
No,
I'll get
we're
Emma
not.
on that.
we're not.
This new grading system that's going to be a lot easier to understand and reduce ambiguity and anxiety. Absolutely.
Do you want to pick one from there?
Yeah, let's do it. Okay. Top tips to maximize IVF outcomes with 3 months prep.
I've seen this do magical things to people. So I think, first of all, you need to weigh up whether you've got 3 months in you. Okay. So 3 months, if you're 42, you haven't got. You need
Oh,
to be
right, yeah,
like, if you, unless
yeah.
there is a reason for you to be waiting 3 months, then I think you need to be cracking on if you are with age related infertility. So advancing maternal age. But if you have, I've seen some patients really work hard for 3 months, and the 3 month prep is you see a nutritionist, you make sure you're on all the supplements, obviously you cut out all the processed foods, all the alcohol, everything goes. You live a bit of a sedentary, boring life for 3 months, no doubt.
Yeah.
But I have seen it totally change people's
Wow.
fertility. Like,
Do you think
especially
that's-
it's been, yeah.
You think it's like, of course, physical, but also there's something going on in someone's like head where they're like, right, I'm getting in the zone now.
Yeah, I think that's that. But also, the eggs take 3 months to be produced, and so do the sperm. So it correlates to the health of
course.
what you
I
give
see.
us
Yeah,
in the lab to what we get to work with. Embryologists are wizards, but we can only work with the quality of what we're given.
Yeah,
We can't make stuff better. We can't reduce the age of the eggs. We can't take away genetic abnormality. But if I've seen patients go from only getting like 2 or 3 eggs in a cycle, then going through a massive 3 month overhaul and getting 8 eggs. You're not going to be one of those people that gets 20 eggs, but if you can give us more eggs, then we've got more at the top of the funnel
I
to
see.
work with.
Yeah, more chance.
So I think there's a lot in it. I think that especially for male health, if sperm takes 72 days to be produced to the time they're ejaculated, I think there's a lot in it. And you definitely see men that have been really ill 3 months ago when they do a sample, it's really poor because actually the effect is from when they were really poorly 3 months ago. So I think there's a lot in it. And I think people should, if they can, invest the time. And actually I've seen people do that and get pregnant naturally. So I think there's some really good nutritional experts out there that can help with all of this.
Yeah.
I wouldn't profess to be one of them, but
But you've got actually your friends Emma the Embryologist on your website.
So Mel Brown's one of my favourite people on
Yeah.
the planet. She's brilliant.
So do check out. There's a link on the website. Just some people that Emma works with that you know in a different part of the world of fertility that can support patients that Emma can't offer, or the clinic that she works at. So yeah, do go check them out. You mentioned about like you are wizards, but you can't change the age of an egg, for example. Like again, coming back to that question about the future, do you think at some point technology will be able to reverse the age of an egg? I mean, that sounds very science fiction, right? But
No, I don't think it does. And I think there's some studies going on at the moment in mice about bonkers stuff in ovaries that are making them more able to. Yeah, no, I think you're probably onto something there. How it's going to come about, I don't know, but and whether it will come around in my lifetime, I don't know. But it's you've got to remember that our first IVF baby's only 46.
Yeah.
Like Louise Brown's 1978, so she's 46. So, and if I can't even tell everyone what's happened in the last 10 years. That is the way this landscape has changed so quickly. I would say watch this space, because I think there's stuff like that coming for sure. People are trying it. People are trying everything.
It's fascinating space. Absolutely. Okay, we got just under 10 minutes before we wrap up today's AMA webinar.
Oh, that's a nice one.
This one here.
Yeah, what Emma said there.
Thank you, Emma, for sharing your kind words. Thank you so much for doing this. You too. It's our pleasure. It's an absolute privilege to get to chat with you today. And we are hopeful that these sessions are helpful. And if, of course, we won't be able to get through all of the questions today that we've had come through on Instagram and on the live chat right now, and also when people registered. But please do keep them coming. We will use the questions to help also write some articles and do some future posts on Instagram just to try and address them and help folks out there. We do have some more from the people that registered earlier on. So should we take this one from Louise?
Yeah.
Okay, so Louise asks, what sperm selection methods do you recommend for a patient with high DNA frag, 49%, and severe oligospermia, 5,000 per milliliter, caused by late maturation arrest? Is ICSI sufficient? What about PIXI, Zymot, IMSI, etc.?
I think we've got a couple of questions around that. So let's talk about what they are. So high DNA frag is something that's been associated with recurrent miscarriage. And actually you can see it sometimes in embryos. They really struggle to develop because an embryo is driven by the mother's egg, the maternal egg, up until late day 3. And then on day 4, the embryo itself switches on its own genetic control, which is why when embryos fail between day 3 and day 5, they look okay on day 3 and then they don't make it to blastocyst stage. People always say it's the man. Well, actually, it's one of two things. It's either the embryo itself. So if the information isn't correct, so if the embryo is genetically abnormal, it will also shut down.
Yeah, I see.
Okay. So it might be nothing to do with the sperm, or it could be to do with the sperm. So we see a lot of embryos fail and then we find a male factor. So male factor can come in varying forms. It can be severe, which is what Louise is describing as very severe. Maturation arrest is something that's actually going on with testicular failure. And unfortunately, with certain parameters around severe male factor, you never really find out what's causing it, and there's not much you can do about it. So your answer for these cases is to do what you can to try and get the DNA frag to reduce as much as possible. Unfortunately, a Zymot is quite difficult to do on low sperm counts. You can, but I would also say if you're going to use a Zymot for high DNA frag, you need to make sure that it actually does the job it's meant to do, which is reduce the DNA frag. So you then need to get into conversations about doing a post-Zymot DNA frag check to make sure it's not made it any worse. Otherwise, it can be quite counterintuitive. I've used IMSI for years and saw absolutely no difference. IMSI is when you look at the sperm under 6,000 times rather than 4,000 times to see if you can visually assess it better. Hand on heart, you can't. I don't have a lot of relationship with PIXI. I've tried it. I've done trials on it. I quite like it. It's very easy to use. Again, I've not seen any increase and I've not seen any studies to suggest. So I'm a bit of a believer in evidence-based. I do think there is a place for a Zymot. I really do. It's a lovely bit of kit. It's how you prepare the sperm, and the idea is that you're almost putting it through a bit of an obstacle course, so you get the best ones through this little slide. But when you are dealing with very, very severe male factor that can't be corrected. So what I will say is some men have got really high DNA frag from really bad lifestyles. Vaping is about the worst thing you can do for your sperm.
Really? Wow.
and crack cocaine, but that's probably not something
Yeah,
for the
it's not.
entire conversation today. But vaping, which is now so common, is one of the worst things we can do for sperm health. So things like that you can definitely correct, right? So you can stop vaping and then it will start to change. And so there's definitely things we can do for DNA Frag. But when it's in a situation like Louise's, it's incredibly challenging because you are up against something that probably can't ultimately be made better. So what we need to do is work with what we've got and try and do the best we can.
Yeah.
So, yeah.
Thank you for your question, Louise. We hope that helps. One of these. From Jody.
That's a good one.
Yeah, you want to take that from Jody? Thank you for this. Thank you, Jody, for your question. What is the live birth rate for a 5-day 3BB embryo that is tested normal after thawed, biopsied for PGTA and refrozen? 40-year-old woman, 1 live birth and 3 failed FETs, all untested embryos from the same batch.
So the fact that it's been thawed and refrozen shouldn't really change its outcome at all. If it's handled properly, you can thaw embryos out and let them recover and then biopsy them and then put them back in the freezer without too much harm. My clinical pregnancy rate from doing that is identical, whether they've been frozen once or whether they've been frozen twice. They do tolerate it. I think it's something that people are scared of, but actually you can do it. As long as they're handled okay, it's really good. So what's really interesting about PGTA tested embryos is the age-related success rates goes away, because the reason that age-related success rates goes down is because you are making more abnormal embryos that are less likely to work. Once you are dealing with normal embryos, it doesn't matter how old you are, everyone's pregnancy rate and live birth rate is the same.
That's fascinating.
So
that is fascinating.
with a day, so at our clinic, for example, the live birth rate with PGTA tested day 5, I'm presuming, let's call this a day 5. The day 5 embryo is 57%.
I see.
And it doesn't matter how old the uterus is. It's to do with the age. It's to do with the age of the egg. And the reason it's to do with the age of the egg is because of the chances of it being normal.
Yeah.
But once you put normal embryos back in women, you get like a plateau of pregnancy rates. So you normally get pregnant with euploid embryos around about the 65, almost 70% mark. There is still miscarriage. We can't stop miscarriage. We can't change it. It's definitely lower. I think the miscarriage rate with PGTA tested embryos is about 11%, whereas in the natural order of things, it's about 25%, 22% in natural conception. 1 in 3, 1 in 4. So it's definitely lower. We definitely are negating the miscarriage cause, but I think it's really interesting to say that actually what I tend to see is day 5 live birth rates with PGTA tested embryos is about 57, nearly 58%. And then it drops a little bit with day 6 to 52 because you've got that day 5, day 6 thing we talked about earlier.
Yeah.
But it gets to the point where I don't know. Your age means nothing then, because as long as we can get your uterus to function and we can get a lining and we can make it prepared, then.
Is that related? You did a post on abnormally fertilized embryos. Do you touch on that within that?
No, that's called atypical fertilization,
It's the
and
atypical, right.
so that's
another topic, isn't it? Yeah.
That's something I'm actually doing. We're doing a presentation on soon at the conference because it's a big deal.
Yeah, absolutely. Thank you, Jodie, for that question. So, Jocelyn, 34 with AMH12, male factor morphology, but success fertilization of 4 about 8 eggs collected through IVF. We had a day 3 transfer of 2 times 4 cell embryos, first IVF cycle. What test considerations guidance would you suggest for a future round?
This is going to be a quick fire round because we're nearly done, aren't we? So,
Yes.
so first of all, 34 with an AMH of 12. So with an AMH of 12, I'd expect you to be getting more than 8 eggs. I think your stimulation needs looking at. Through IVF, so that's only 50% fertilization. Without knowing what the other eggs are, I think you probably, I'm hoping they did ICSI because you said they've got male factor. Anyway, regardless, a day 3 transfer of 2 4 cells. So embryos should be between 5 and 8 cells on day 3. So unfortunately, those embryos were quite slow. I'm hoping you were told that. What would I consider next? I'd actually want you to see someone that I'm hoping the male factor's been addressed properly, which would mean a urology referral. You're only 34, so you have got some time to do that 3 months work and make sure you've seen someone. You absolutely should be having ICSI, and given that your embryos are not getting to the right place at the right time, I'd like you to be under time lapse as well to see what on earth's going on and why they're slowing down.
Yeah.
You might need a continuous culture. You might need to be in a different lab. I hate to say it, but we're not all created equal. Some labs are just better at culturing embryos than others. But I think that male factor, given you're only 34, desperately needs, like, you need a urology review. Someone needs to have a look at your partner, make sure that, you know, you haven't missed something that can be changed. And then I'd look at maybe getting a second opinion and getting some stims sorted out, because with an AMH of 12 at 34, I'd expect you to be getting 12 to 15 eggs.
I see. Great advice. Hopefully, Jocelyn, that can help and give you some next steps. So we want to do one more.
Do one more.
Sneak one more in. Yeah, we have gone over. So thanks for sticking with us, folks. Very grateful for you going past the hour. I know we're breaking the rules here, but why not? Which one would you like to take as a final one? I can scroll back up if you like.
No, go down that. But last one was quite good. This one from
Tony. Okay, so Tony asks, thank you for this question. Is there an average number of untested day 5-6 embryos that gives you a good chance of a live birth at age 37? I.e., how do you know when to stop banking
such
embryos?
a good question. It's so hard when they're not tested, and I do understand why people do and don't test. So we just have to go with the statistics, Tony. So you're 37. The chance of each embryo being normal on day 5 is around, I can't remember the numbers, I think it's 52%, isn't it, in that age group? And then on day 6, the chance of an embryo being normal is about 46, 45. There's always a drop of about 6 or 7%. So I think you need to look at it from that. So if you are, you know, banking embryos for the future to give you a chance of a live birth, one live birth, I'd say maybe three or four. If you're looking to create a family, then unfortunately this is where PGTA comes into its own, because at least you know what you've got in the freezer. Probably 5 or 6 to be really sure that you've got a good shot at 3 of those embryos being euploid, if not hopefully 4 in this age group. It's a really tricky one. And I would also be looking at the time lapse and the grades and stuff like that to see if any of that, because a lot of that correlates to the potential chance of the embryo working. So you can have that conversation if your embryos are under time lapse with the team to make sure that they've seen good divisions, good normality, how do they look, all of that. So.
Great advice for Tony. Thank you for sharing your question. Okay, folks, we're going to wrap up today. So thank you for being part of this AMA, and thank you so much for all your questions. Incredible set of questions. Apologies that we didn't get through to all of them.
But they're amazingly helpful. They're really helpful because I can start building posts off these as well. Absolutely. So there's obviously a common theme in a lot of them. So I can use that to help build posts that will then hopefully come as a more generic posting type thing that I can start to help.
So for those unfamiliar, you can follow Emma on Instagram, so at Emma the Embryologist. Also, do subscribe at emilyembryologist.com. You'll get access to the newsletter. You'll also be able to access our podcast. So we're going to do a lot more podcasting, perhaps not as webinars, but we'll record some conversations. We'll dive into some deeper topics. Some of the things that we've talked about already on our podcast, we have discussed IVF 101, just right back to basics. That was a good one. We did a whole one on PGT. We had a discussion around donor sperm, and then also the Vienna consensus and choosing a clinic. For some articles as well, we mentioned a few already. So the 10 essential questions to ask during your consultation. We've got the glossary. Emma talks about her personal story that she's been through. The role of an embryologist, that is a really good post. Bigging up all the brilliant embryologists out there. And then the abnormally fertilized embryo post as well. Worth checking out. Head over to emilyembryologist.com for that. Do subscribe, do sign up, keep the questions coming, keep looking out for each other. We're very grateful for you being with us today. And we wish you all well. And we'll see you next time.
Thank you, everyone.
Take care, folks. Bye for now.